the AI and how we can implement inside our practice in the healthcare sectors. And whenever I'm implementing a new solution, whether it's an or integrating devices or creating a patient portal and so on, the first question that comes to my mind, where is your guidelines? Where is your process, your governance? Do you have any ethical standards that you are going to follow? And if the answer is no, I always jump, where is our quality department? Because guys, we always look to the quality department, that they are the big group of people that always put us back on the track whenever that we are deviating. You are our reminder of the guidelines and the best practice and all the standards and that we have to follow. And sometimes we are not following it, either because of human nature to deviate, or it's because we just simply forget. So thank you so much for joining today. I will move to the objectives of this meeting. So first, I would love to introduce you to the AI and the automation and the difference between both, because sometimes there is a touch points between both technology and we are not aware of what is the AI is meant to be. We will quickly go through the different types of the AI, and even if you are not using it inside your facilities, you are using the AI every single day of your life. And I will give an example of the real life different types of AI, so it will give you the sense that you are already an AI user. How the AI can improve the predictive analysis and the clinical decision support system. We will quickly cover the clinical decision support system, that is, everyone is using it, even if you don't realize it, but you are using it either on paper or you are using it on your EHR. We need to understand the ethical consideration of the data privacy, the algorithm bias, and how we need the staff to be trained. And also discover if there is strategies, because there is different strategies and methodologies that you can implement to empower the healthcare teams and achieve the patient safety and quality of care at the same time. We are happy to receive your questions if you want to put it on the chat box, or later we will give around maybe 15 to 30 minutes for discussion. So we will move forward of the introduction to the AI, and it's a very simple understanding of terminology. What do we mean? I added some bold statement words and underlined it because it's very important to understand. So the artificial intelligence is building a machine that can deal with big volumes of data. So we are talking about your own data. We are not creating new data. This system will learn from the past. So you have to take care of the past. So if you have a future plan to go to an AI, it means that this is the right time to clean your data, to make sure that it makes sense, to look into the quality of the wording, the quality of the terminology that you are using inside your systems. It learns by experience, and it performs like human-like tasks. So no matter how advanced the AI, the technology or solution that you will implement, if you don't have a human or people engagement and understanding and buy-in, then we have nothing. It's simply meant to not replace anyone. It will enhance the speed, the precision, the effectiveness of the human efforts. So again, the main key player of the AI success, it's what is a human is doing, either during the training stage, building policies, putting processes around, sending guidelines, what are the ethical standards that you have. So I want you to look to the AI solution, whatever you will implement, as if it's your own child. There is a lot of behavioral and psychological studies that had been done before, comparing the human behavior when he's adult, when he's raised in different environments. So I want you to remember there is a very famous psychological study done before about identical twins when they are separated, and the two people who are meant to be one, genetically they are the same person, but they are raised in two different environments, and the adult outcome, it can be one is a police officer and one is a criminal person. So the AI is the same. The AI is a brain that depends heavily on you to train to teach manners, to teach ethics, so it will grow in the right person. Then what is automation? Automation is different technology. Sometimes they have touch points, but it's different that it automates the processes. It doesn't think of its own. It just it has a minimal intervention from the human, and it keeps things working. It's like what you sometimes watch on videos on social media, where there is a robot is doing the same thing over and over and over again. It doesn't need any human intervention to it. It's just repetitive of process or steps. The chatbots that you have on your mobiles, for example, if you're going to your mobile bank app, and there's a chat box, and you ask the chat box, and the chat box is giving you fixed answers that the human customer service would give you. If there is anything that requires thinking, requires decision making, requires problem solving, then the bot will automatically tell you have to connect to the call center. So the automation is a machine that performs tasks only, and it's impossible or difficult when it's performed by a human. So for example, if you look to the heavy machines used in a construction field, instead of requiring 100 or 150 person to carry a heavy block of cement or heavy equipment, then you are using one equipment moving with one human back and forth. This is a type of automation, but it doesn't have a lot of intelligence inside it. Okay, so moving to the next. Okay, so what are the AI? What is the different types of AI? So if you look to the image that we have on the bottom of this slide, you will find that the AI, it's vast and big volumes of data, and there is a machine or a brain, artificial brain sitting there, that it will learn from the data, and then it will push to the intelligence system. So again, look to the picture in the middle. It's your data, it's your data, it's your data. The nightmare of any AI that you have inaccurate data, or if you have no governance of the data, or if you don't have a proper interpretation and deep knowledge of your own data, because you are going to train the machine on this data. If you don't have the right person training the machine, analyzing this data properly, utilizing data sets, telling the machine which exact data that we need to have the right outcome, then you will end up with an AI bias. So based on the capabilities of the AI, there is other types of AIs, but these are the main types that we use in our daily life, and we are optimistic that we will be able to implement some of it into the healthcare. So look to the narrow AI. So the narrow AI, it's exactly called the weak type. So are you using narrow AI? Every single time you look to your mobile, you are using a narrow AI. It's the facial recognition. So if you are not using a password to open your mobile, and you're using your face recognition, so you're using the AI in every single day. Okay, so this is how simple that we are using AI without knowing it. Most of the AI, this is why it's very simple, because it doesn't have a lot of tasks. It has one task: recognize my face. That's it. It doesn't do anything else. So usually the narrow or a weak AI, it makes one task and not a multiple tasks. Then we will go to the second type. What is the general AI? So the general AI, it's broader. It has a capability to make new unfamiliar tasks automatically. It learns by itself, and it can utilize a lot of intelligence and the challenges that is needing human guidance as well. Then we have the super intelligence. To be honest, most of the super intelligence now, it's a hypothetical, something that we want to reach, but it's not yet in 100% developed. It's mainly that it's mimicking the human intelligence across all fields: creativity, general wisdom, problem solving. So if you will look nowadays on the social media, you will find some people, they are trying to make videos of the AI, taking a famous actor or actress and putting them, creating voices behind and the same voice and so on. So these kinds of creative AI is the future super intelligence. As you can understand, the super intelligent AI is one of the future most dangerous type of the AI if we don't have the right ethical standards around it. So let's move to the next one, which is based on the functionality, what AI is able to do. You have the reactive AI, and this is, again, it's like reactive. It gives a kind of responses to you. So if any one of you have Alexa, and you ask Alexa to give you a song or something like that, so it reacts to you. Sometimes tells you, sorry, I didn't get it. I didn't understand what you're asking for. So this is a kind of reaction. I like to play with my Alexa when I ask her to do something for me. At the end, I say, thank you, Alexa, you made my day. Then she will answer, you're welcome, it's my job. Every single time, regardless of what I ask Alexa to do, every single time I tell her, thank you, Alexa, she gives me the same response. So it's a kind of a limited reaction, but it reacts like a human. Thank you, you're welcome, you made my day, I'm happy to do it, it's my job, and so on. So this is giving you how this is a reactive AI. Then the limited memory. The limited memory, actually, it gives you some of the decisions, but it doesn't keep a very long memory of you. So let's say that every single day I go to my work, I put the Google map. So I put the same location every single day. If I tried in one day in the same time not to go to my work, but I'm going to my kids' school, once I open the Google AI, and you can try this the next week, just on a daily basis, set up your work location on the Google map. Your weekend, just go and open the Google map. Immediately, it will suggest your work location. So it has a limited memory, but it can suggest you places depending on the pattern that you're using every day. Then the theory of mind. Again, this is a very advanced type, and the name is so obvious. It's a theory that we are saying that it will be able to understand emotions, behaves, need, depending on AI to make decisions and so on. So it understands the human. And again, this is a kind of theoretical, but if you have the updates of the Apple, the new iPhone, and you go to the WhatsApp, the new version, you will be able to see something called Meta AI. And the Meta AI is giving you some psychological and emotional advices. So you can go to the Meta AI and you say, I feel down today. What should I do? And it will give you very, very, very nice advices on how you make your day better. Then the self-aware. This is a completely future, but it was discussed in a lot of movies that the AI will have their own self-awareness, their own feelings and their understanding and beliefs and desires. This is the most scary one for us all. So the last group that it's related again to what is the technology that we use it. So there is a machine learning, and this is a self-improvement. So what happens in the machine learning is it's F-then rule. So imagine that I want, let's go to more examples on the patient safety. The fall risk. It's one of the AIs that I'm really interested in building. It's related to if the patient is this age, then the risk of the fall is going to be like this. If the patient is a pregnant woman, then the risk is like this. And all the criteria that we have either in Morris for risk or in other tools or Humpty Dumpty, all of these risk assessment tools that we had been using on papers and on the systems for years now. I want you just to imagine an AI that can use these huge historical data. I made a very quick study before and in one of the organizations, and I came to know that we have more than 20,000 fall risk assessment done per month. So imagine that you, over the last 4 years, what is the volume of data? Human being had been building the risk and putting the data to an electronic or paper format, calculating the risk of fall, and how can we push this huge data that there is no human brain can sit on, and push it to a machine to learn, to predict the fall of these patients depending on their clinical condition, their age, their gender, whether pregnant or not, adult to child, and so on, limping, and so on. And you will be able to open the patient file, and then the machine is sending you a message telling you that there is a risk of this patient falling. Futurely, as a futuristic vision, I would even imagine that we have a camera sitting on the front doors of your hospitals, using these analysis, looking into the patients, how they move, what is the age, and so on, and predicting therefore the risk of falling, and just sending alarm. Maybe if the patient passed by the camera, the robot can stop them and say, hey, we identified that you have a high risk of falling, and we would like to give you a sticker. They can give you a barcode, they can give the patients, and so on. So everyone in the hospital knows that the patient has a higher risk of fall, and they can proactively prevent it. So these are the kinds of the machine learning that you can implement. Looking to the deep learning. The deep learning is somehow the next generation of the machine learning. It goes too deeply into the layers that you have of the information, the neurons layers. So this is how we build the technology. It's very, very complicated. It doesn't depend on if-then condition, but it depends on multiple data that is coming from the lab results of the patients, putting to it the family history, looking into that he was recently admitted to the hospital, looking into the vitals, the last vitals that we did, looking to the patients was yesterday in the emergency, and building for you a predictive results around the patient. The natural language processing. So nowadays, if you open a Word document and you try to type anything, whatever you type, this is a human language. Not every single AI technology is able to understand the free text and the abbreviation that the human would use it typing a free text. So there is a specific technology called natural language processing, which is NLP. So if you are aware that your doctors and nurses and people using your systems in the facility, they tend to have a free text a lot, and now you are sitting in a selection committee looking into an AI solution, I would recommend that you go to the technology of the NLP. If you are aware that you are using structured data like the SNOMED, like ICD-10 codes, like CPT codes, then you can use different technologies. But if you are looking at free texting notes, then we are talking about the NLP, that this is the best technology that can help you to achieve the outcome. The robotics that you are using in your theater, it's a kind of AI, so it's operating robotics. So any kind of robots that you are using, it's an AI. The technology, the computer vision, it allows the machines to take, to make an interpretation and to connect the different applications. Usually we are using the computer vision if you have an AI in imaging. So if there is nowadays a lot of AIs that sets in the digital histopathology labs, there is images that analyze the mammograms, it analyzes MRIs, chest x-rays, CT scans, and so on. So I'm familiar with facilities here in Abu Dhabi and in Dubai that already implemented an AI that sits on the CT scan for the stroke cases. So before even downloading the image, before the radiologist is sitting on the image and interpreting it, the AI is sending alarm to the emergency department and to the neurology and the stroke center team saying that we have a patient with a stroke. The expert system, it's again, it's answering questions, it's a problem solving. And if you have one of the solutions where you are typing just how can I build this, then you are using the expert systems. If you are using chat box, you are the chat GPT, you are using expert systems. So anything that gives you an opinion on a problem solving, this is coming under this category of AIs. So we will move next to talking about the role of the AI specifically into the patient care and patient safety. So like I said, it's a predictive analytics, like the example we give on the 4 risk, like the diagnostic assistance. So sometimes that the doctor will busy seeing 40 patients a day, which is by itself is considered the risk in some of the regulatory, like in the UK, they put you a limit of patients that you are able to see. Here in the UE, the doctor can see endless number of patients. So the diagnostic assistance is very important in such a busy organizations, because the doctor will type and say that this patient has a fever. The fever had been for 3 days. They have sore throat. In the clinical examination, I noticed that there is congested tonsils, some of the maybe white spots on the throats. There is there is cervical lymph nodes. It's tender. The patient has swallowing difficulties, and enter then the AI will diagnose that this patient has an acute follicular tonsillitis with a fever and suggest the management plan for this patient, where the doctor can, okay, the management plan comes from your guidelines. So what is the first choice antibiotics in these cases? What are the painkillers? What are the topical analgesics that we can use it as a mouthwash or something, and coming to that we suggest a dose of Panadol and so on. So this is called a management plan. It pops up with the diagnosis to the doctor, and the doctor acknowledge they have the right to modify, to add on, or to remove something. If they think it's a viral infection, for example, then they can remove or overlook the antibiotic and so on. The other thing that it's related to the treatment optimization. It's more of a risk management. Again, we have, for example, nowadays in the DOH, they are stressing on the stewardship antibiotic for the inpatient and outpatient. So the treatment optimization, let's say that I choose for one of the patients a specific type of antibiotic, but I didn't have the time to go through the culture results. This is not the right antibiotic. So if you have an AI that can set a rule of the clinical pharmacist, looking into the culture, the results of the patients, and then it can suggest to the doctor pop-up message saying that this is not the right antibiotic to be used for this patient according to the culture, and the suggested antibiotic is this. So you are optimizing your treatment. You are automatically complying to the stewardship rule according to whatever the guidelines that you build on the system. And at the same time, you're improving the quality of care that you provide to the patient. So this is type of the treatment optimization AI. The remote monitoring is an AI. So every single person of you using the Apple AI or the any type of watches, digital watches, that is, you are putting how many steps you are doing every day. You are making an ECG. Now there is an ECG monitor that you can implement from the Apple stores, watching your blood pressure if you are a hypertensive patient and so on. So this is a kind of a remote monitoring which analyze, and there is a message comes to you saying that your blood pressure is high today, or you have a changes of your ECG. We recommend that you call your emergency doctor. So this is a kind of a remote monitoring. If you are if your facility have, and again, you may have you are currently using AIs in your facility, but you are not aware that you are using. So if you have a virtual ICU, if you have remote monitoring, if you have monitoring of your patients sitting in their homes as a home care and so on, you might be using a very simple solution that depends on the AI, but you are not aware of it. And the reason, and this is one of the most risk that I see in the Middle East specifically and generally worldwide, when the quality department and the clinical team are not involved in the technology implementation. So you might end up with that you have an AI solution running in your facility. You don't know that it's there. And the reason is that we didn't develop a governance of the AI and technology implementation in our facilities. I will move forward to the next step, and there is a slide where I will look in. This is a slide, the challenges and the concentration to implement the AI. So the first thing is the interoperability of the data and the data integration. So what's happening, and I will give you a real-time scenario. There is an integration of the arterial blood gases that's happening in every single facility that we have an EHR, and whether it's a small system, it's an EMR locally developed, or you have one of the big names like Epic, Cerner, TrackCare, and so on. So what happens is the integration team is integration engineers, right? So they will go and the ICU doctor will say, or the nurse will say, we want this machine to send the data direct to we don't need manual entry. So this is a kind of automation or an integration. So what they will do, they will plug in. Simple, very plug in, and the machine will send the data. But in real life scenario, if the proper clinical informatics and the quality team, they stepped in, and we need your sign off before we plug in this machine, we will understand that some of these data are corrupted data. And the reason is that if the sample of the arterial blood gas is clotted, and we put it, we get panic results. It's a fake panic results. It's not real. And we have to recollect the sample. But in reality, when the integration engineers, they don't follow this governance or this process of approval and sign off, they will go give the user what they want, plug in the system. And now this corrupted panic or fake panic results, it's on the patient data. Okay, and the interoperability. Now the HIE, like if you are in Abu Dhabi, it's called Malafi. In Dubai, it's Nabid, and in the North Emirates, it's called Riayati. Everyone is aware that there is a lot of doctors, they are putting diagnosis for insurance purposes. So I'm putting that the patient has a disc prolapse just to get the MRI approval, but basically, I will never be able to say or to judge that there is a disc prolapse except if I see the MRI. But I'm putting it for approval purposes, and this is the data that is integrated and the data inaccuracy. Looking to the second challenge that you have, if you suggest an AI implementation, it's the cost and the return of your investment or the return on your investment. And if you don't have a team or a person who's taking care of your clinical informatics, it will be very, very difficult and challenging to build a return of investment or to convince your stakeholders to invest into AI or any other solution. The clinician engagement, and this is a very, very tricky part, because if you didn't get the buy-in from the clinicians that they are involved with, so which human brain are you going to use? So if we are saying, and I'm not saying clinician by physicians, it's nurses, it's physiotherapists, it's everyone that work in the healthcare. So let's imagine that we want an AI that can predict a diagnosis. If you don't use a physician to mimic his brain and how he think about the diagnosis, so you don't have anything. If you didn't use a nurse to validate the predictive AI that calculate the risk of the fall, because she's the one sitting on the fall assessment, the risk assessment every single day, then you have nothing. You don't have anyone to validate your data. You don't have anyone to validate the outcome. You don't have anyone that is going to use the tool. So you might end up with the most accurate, excellent tool in your system, but no one is interested to use it because we didn't engage them in the decision making. The patient privacy and data security. This is another risk that we have to put, or a challenge that we have to put in mind. But again, if you have the right governance, you have the right communication with the cybersecurity team, with the data privacy officer, sitting together, building up the governance around the data privacy, what can be sent to the AI machine, what cannot be sent to the AI machine. So I was sitting in a meeting a couple of days ago, and we were discussing about using an AI to automate the booking of the scheduling of patients to save the time of the customer service. And I was thinking of that like this, the AI will see that I'm trying to book an appointment for a psychiatrist. Can we allow them to do that? So again, this is a highly confidential information from the patients. I don't want, so we agreed that all the appointments that is need psychiatric or a psychological evaluation, the AI is not going to be responsible for the booking. So the AI will never see these clinics or see the availability or see the patients or even take the calls of the patients trying to book for these particular services. And the same apply for the other specialties depending on the guidelines that we have. The regulatory compliance, one of the most challenging, and everyone is aware of it, that in UAE you cannot send any medical data outside the boundaries of the country. So we cannot utilize an AI cloud that sits outside UAE. So this is very important while you are discussing or selecting an AI. Don't waste your time with companies that they will tell you that our AI or our data is sitting in a cloud and the server is in China or the server is in one of the African countries or in the US. So don't waste your time on this, because you will be definitely non-compliant to the regulatory, because your data will be sent to the server where the AI is sitting outside UAE, analyzing and sending you the answer back. So it will be a huge legal liability on your organization. The algorithm bias, and again, you can override this by having the right guidelines, the right policy, and the right process in place. The last thing is the clinical autonomy and responsibility. Please don't implement anything that takes the autonomy from your clinicians. We implement it as a clinical decision support, and it's not a clinical decision making. We will move next. Okay, so what does it mean by the clinical decision support systems? I will quickly cover this. It's tool, and this tool can be on paper, but nowadays we are implementing it as computerized. It helps the physicians and the nurses to take clinical decisions. If you have, for example, implemented any of the risk stratification tool on your system for cardiovascular disease, for chronic kidney disease, this is a clinical decision support systems. And the thing is that why we want it to be in AI now, because we can suggest more. It's not that risk stratification. Okay, then Dina had a high risk to develop a DVT, then what? So the AI can suggest guidelines, can suggest the management plans. It can put an alarm to the patient file. It can tell you how to move forward and what is the best selections of the treatment. Should I give the heparin for 7 days post-operatively only, or should I give it for 30 days after discharge of the patient from the hospital? So both of them, they are high-risk patients, and both of them developing the same disease as a DVT, but one of them, they are older in age, or maybe one patient had a major operation recently, so the risk is much higher of developing DVT. So we would like to give them the prophylactic heparin for a longer period of time. So this helps them to dynamically change their decision and have a full benefits from what you have on the health records and what you have inside saved for these patients for a long period of time. The clinical decision systems can be a passive, like it's a popping up alarm to the doctors, or it's an active one telling, would you like to move forward? Like push it for a referral. For example, this patient's identified that they need to see a nephrologist. Would they like to move? So this is an active AI, clinic decision support. So moving next, we will talk about some examples of the AI in the clinical decision support. So you have a lot. You have, for example, a sequence AI, which is a trigger, like a specific ordering of medication. There is an input of data, and this input of data doesn't require manual input. It's pulling the data from the patient lab result, like the creatinine value. And then there is an intervention giving options to the doctor, saying that this patient is having a renal impairment. We need to modify the amikacin dose. Okay, so, and these are the recommended doses for these patients. And then the doctors will make the action step, or the AI will do it for them, suggesting that, would you like me to change the dose? Then you acknowledge it, and the dose is going to be changed. This is one of the sequence that we can use. Another multiple examples, it's related to the predictive AI, analyzing clinical and non-clinical data, gives you risk of disease prediction. Like now there is if the female, she has multiple female of first degrees with the breast cancer, and now her age is like this, and she's breastfeeding or non-breastfeeding, and what are the risk factors? Again, there is a pop-up predicting that this patient has a potential of developing a breast cancer 75% within the next 3 years. So you start putting her on a mammogram screening every year instead of 2 years, and so on. It can be to proactively preventive measurements, like early detection of the colonic cancers for males, who have a positive family history of the first-degree males. So what happens is the regular guidelines is telling us that every single male above the age of 55 should have every 2 years or 3 years the screening for the colonic cancer, right? These are the guidelines. However, the patients that they have a first-degree male colonic cancer positive family history, they start this screening 10 years before, because their risk is higher and so on. So this is one of the preventive things that we can do. Tailoring medical plans for individuals. Some of the pharmaceutical companies is doing that. Personalized care plan, precision medicine. You are hearing about this a lot in a lot of conferences nowadays. Enhancing the patient engagement and adherence. So I'm looking at a new AI where we can put it on a patient portal and for asthmatic patients. So every single day, the AI will ask the mother or the patients to put how they feel today. Do you notice that the weather around you in your area changed? Do you have a lot of winds today, or it's rainy? How many times do you have the night cough this week? Did you need your Ventolin, and so on? Then, and the AI will build a scoring with a recommended management plan saying that I think that you are in this stage of your asthma today. Make sure that you are compliant to your medication. Don't go outside, and book appointment with your pediatrician. While if the risk is very high, then we will tell them that you need to address the emergency and make sure that you take a Ventolin puff every 20 minutes. So this is one of that it's an engagement with the patients to take more control into their health. Next, please. The next slide. Yeah. So what are the strategies that you can empower your healthcare team to achieve more quality of care and patient safety? So I like to use these 10 steps. It's very easy for me to implement a solution, whether it's an AI or any other electronic solutions. First, define your objectives. And this is for me, it's a success or failure step. If you don't know what you're looking at and what you are trying to build, you will end up with disfigured solution, where the understanding of the engineers and the AI developers, it will be the leading or the change driver, where you want to lead. So if you have to understand your objectives, what are you trying to achieve? You have to get the buy-in from the stakeholders, especially for the clinicians or the front-end users. They are the one who is going to receive the message. They are the one who is going to receive the production. And there is a production is coming saying that this patient is going to develop a breast cancer. If there is no doctor engagement and he's not going to move forward with putting a proper schedule for the mammogram for this female, then you have nothing. The step 3, make sure that the quality of the data is available. It's very, very important, because if we end up with inaccurate data where the diagnosis is done depending on the insurance plan and what is the doctor is trying to get approval or not. So that's why your engagement with the clinical documentation improvement team is essential to make sure that your data and your clinical documentation is accurate before moving forward. Find the software and vendor that you can work with, and again, make sure that you are compliant with the requirements of the DHA and DOH moving with them. Make sure that they have a license. So there is a specific license for the AI that they have to apply for to get it from the regulatory in UAE. If they don't have this license, please don't sign a contract with them. Determine the scope and the features that you're looking at. Look for the best integration and strategy in your workflow. Do you want the full risk assessment to happen before seeing the nurse or after seeing the nurse? And in which step on your workflow, you have to agree on this. Make sure that you have a minimal viable product. Don't look for very expensive products, because at a certain stage of the data validation, you might terminate your project, and this no one from the finance would like to waste the thousands over that. Make fine-tuning according to your needs. Make sure that your solution is customizable. Get a working product with a proper support. So the first thing that I ask a vendor when they come and they say, did you implement somewhere? And if it's in the Middle East, I can, or in UAE, I can have a site visit. I can talk to the end users. I can test the solution myself and so on. Lastly, and this is complete personal onboarding, and make sure that you have all the benefits there. Make sure that you introduce your solution. Go small, have an agile approach, phase 1, phase 2, phase 3. During moving with agile approach, it's very customizable and flexible approach. So during the phase 1, we have some triggers. We want to add more data for the formulary to work or for the production to be more accurate. So if you have this agile and not the big bang approach, then you will have the more flexibility to adjust your solution. Next, I think we are, yeah. So how to leverage your current. So when I sat with business owners, which is the clinical team in majority of the cases looking into the AI, I sat and I'm really surprised that they want to restart the wheel from scratch. They want to go to square zero. Guys, you had been using the clinical decision support systems for years. You had been using the checklist, the safety checklist in your theater for years. So if you want to have an AI that increase your theater management and the safety inside the theater, please don't go to scratch. Just go to your safety checklist that you had been using for years, take it as a data set, give it to the vendor and say, you know what, these are the safety measures that we are using for years, and these are our historical data. Please train your AI depending on this. Don't go and start all over again, and over again, because this is what I witnessed recently. And I think the reason is that we don't have an understanding of what we have. We have a lot of data. We are sitting on a golden mean of data. We had been using this. We are structured in industry. Like aviation, healthcare is like aviation. We go with protocols, we have standards, we have checklists, we have safety, we have all of these implemented for centuries now. So don't go and start from scratch. So let's say that you have now an expert-driven knowledge acquisition, which is, like I said, you have social assessment, done by the nurses, psychosocial assessment. It's requirements by the JCI, and they had been doing it over and over again. And there is, you have the tool on the system, which is the clicking yes and no checklist. So this is the part where it's saying clinical decision executable environment, and there is a knowledge transformation setting with it, and then there is an outcome. What we propose is that you need to have a data-driven knowledge acquisition. Then you have a hybrid in the middle, which is a solution that is analyzing your previous data, the social or the suicidal risk assessment for patients. It depends on their answers, and their answers is already there in the system. The family history, the social history, the medical history, they are diagnosed of being depressed patients, they are on antidepressants and so on. This is how we are calculating the risk for suicidal tendency, right? And you have been doing for these patients. If you have a tool that can read and fetch data from the patient's electronic records, then it gives you the risk assessment and the prediction of this patient is a low, mild, moderate, or severe tendency for suicide. And then it pops up to the nurse, and the nurse knows the guidelines for the low and for the high level of the risk of suicidal tendency and so on. So please, if you have the intention to start using an AI or an automation, don't go to square zero. Leverage what you already have on the system and engage with the clinical team, engage with the clinical informatics if you have a clinical informatics consultant in your facility. So I think we maybe one slide. Yeah, okay. The ethical consideration, like Dr. Samia, we have a lot of ethical consideration here. So one of the clinical settings, we implemented the AI detection of the patients with sepsis, and they picked up only 7% of the patients with sepsis, and this is delayed the antibiotic administration. It caused a lot of failure. This failure didn't reach to the patients because it was identified by different other means. However, you have to make sure that you validate and revalidate and keep watching your AI. The same, like I said at the beginning, it's your child. You teach them at age of 7 something, but it doesn't mean that they will comply or they will do it perfectly. And you keep monitoring them and you keep reminding them, even if they are 15, 16, you keep reminding them, I told you not to do that, and so on. So it's a continuous learning. You have to improve and develop a frameworks around the AI. You have to have your own ethical standards, what the AI is able to do and what not able to do. You have to set it clear to the development team and to the technical team that in healthcare, the AI cannot be a decision maker. AI in healthcare is not a decision maker. It can support, it can facilitate, it can give suggestion and options and choices, and not a decision. Establish a framework for the clinical errors. Guys, you have been monitoring us for years, right? You're always looking into medication error, administration errors, delay of why you're not doing this anymore to the EHR. You have to step forward and start doing this to the EHRs. Start looking into gaps in your technology that is leading to your medication errors. If you have a patient identification error, look at your EHR and your system currently. Have a more development identified as a problem statement. Look into barcode medication administration process. Look into automation of the dispensing. Look into robotic pharmacy that will reduce the errors of dispensing medications and so on. There is a lot of other challenges and ethics that you can build, but I added some of the study links here that you can look into, real studies that really the AI relate to a lot of bias. Next, please. Okay, so this is the last slide. The takeaways that we want you to make sure that we end up with. AI can enhance patient safety. Yes, it can, but it depends. It can improve the prediction, the clinical decision-making, patient outcome. It can increase the efficiency and automating routine tasks. However, you have to keep an eye on it. Ethical consideration are crucial. Make sure that whenever you have a technology, whether it's an EHR or an AI implementation, that you have the right policies, what they can do, what they cannot do, the limitations, make sure that there is a proper validation in place, challenges to overcome, establish a patient safety safeguarding, please, for the EHR and for the AI solutions and for any automation. Look and go to the integration team, make sure that you look into how they integrated the systems, how they integrated the medical devices, who's responsible for the interpretation of the CTG, if you have automated the CTG, and if you are automating the ECG interpretation as well, make sure that you sit and you look deeply into the validation process that they had. Adapt a strategic approach, and definitely collaboration is the key. Make sure that you connect dots, encourage having interventions and evaluation. And I think that's all. Thank you so much. I'm happy to take questions.
Thank you, Dr. Dina. Really appreciate it. I think this is the first time we had a real experience, most of us, in terms of what exactly is AI in context of patient safety. Thank you so much. Really appreciated your kind knowledge sharing. And the floor is open for any question answer. You can put them in the chat box, or you can unmute yourself and you can ask the question. And you can also scan the QR code which is shown in the screen to give your feedback. So we are open for any questions as of now. So if anybody has any question, feel free to ask. So Dr. Dina,
Hello,
first
Dr.
question is that,
Dina.
yeah, please go ahead. Yeah. Mr. Harris?
Harris.
Yeah, please go
Yes.
ahead.
Thank you very much for presenting the wonderful presentation and clarifying so many doubts related to artificial and intelligence. The only thing actually and the concern is, do we have any regulatory standard or any guideline to what extent we can use the AI in the hospital? Because in the hospital we deal with the human life. So if we have something from the regulatory body, to what extent we can use the AI, it would be very helpful. So do we have anything in DHA or MOH or DOH?
Yes. So you have actually a new federal standards for the for UAE for healthcare AIs. You will find it on both DOH and DHA. However, looking into the policies and the process, I would say that the DHA is more advanced in implementing more standards. So they have ethical AI committee. It's led by Dr.
Mm-hmm.
Khulud Estayef, and they are going through the solution. So if you have an AI that is not licensed by these regulatory bodies, please make sure that they get the license and the registration under the DHA and DOH. So they will go through an ethical standards assessment and make sure that they are compliant for patient privacy, for cybersecurity, for a lot of other standards that they have. So yes, to the answer is UAE, one of the first countries that started implementing AI ethical standards on the country level.
Okay, thank you very much. The thing is, for example, in radiology department, so like Siemens, they are implementing AI system in their machines and all. So we need to look at the company actually. They have this certificate from the regulatory body or not, correct?
Yeah, so if we are talking about medical device using an AI, this is, you know that every medical device to start selling their products inside UAE, they have a medical device registration with the Ministry of Health, right? So
Yes,
during this
absolutely.
registration, if in the catalog or the manual they are using an AI, then they are going through it. So if you have a medical device coming from Philips, Siemens, or any other medical device company, if they have the registration for their product inside UAE, so they went through that. So the medical
Okay.
devices is the least to worry about because it's part of the registration with the country contracts. But if you have an
Mhm.
AI solution implemented and integrated to your EHR, this is the one that you have to ask the question about the license.
Okay. Thank you very much.
Thank you, Dr. Dina. Really appreciated your knowledge sharing. We have some more questions. So we'll go with the first of all the questions in the chat box. So Mr. Mohammed has asked, can you mention examples of AI tool which are integrated with EMR?
Sorry, I'm trying to read it. Uh, Okay, so the AI tool that can be integrated with, like I mentioned, actually, if we have someone from MediClinic here, we successfully implemented one of the CT AI in the stroke center in City Hospital. So there was a challenge on the rapid response team for the stroke cases. And, in the stroke cases, if you want to have the American accreditation for the stroke centers, they measure door to needle time. Okay, and if you are exceeding a specific time frame, you don't get the accreditation. It's one of the accreditation standards. And there is always a delay that happens because a patient comes to emergency, they identify them, may not have a stroke. They send the patients to the CT machine. If the radiology doctor is not available, then what is the technician is doing? Taking the images, uploading it to the cloud, calling the doctor on the phone. Then the doctor will start using their workstations, open, download the image and look into it, put the report. If there is a stroke case, they pick up the phone and talk to the emergency doctor. And instead of all of that, there is an AI imaging analysis AI sitting on inside the CT scan machine itself. Once the images is taken, it goes through the algorithm, it analyzes and read the images, and it's an international solution with very high accuracy rate. The accuracy was around 97%. Then the doctors and the rapid response team, they have the application on their mobiles. They start setting alarms and notifications to everyone, the neurology, the rapid response team, and the emergency doctor. So before the patient comes back to the emergency doctor is already notified that he's a stroke positive case, and the rapid response team is already informed. So this is one of the AIs that I'm really proud that MediClinic implemented. There is a lot of other AI solutions that currently the G42 they are working with, and it has a very, very high success stories. But this is one of the things that I personally experienced. Um, What is the good AI for the Jowda KPIs automation? I would say that all the AI's modules can work on the Jowda KPI automation. The lovely thing about the Jowda KPI that it's so precise. It has nominator, dominator, it has exclusion and inclusion criteria sitting there. So it can be directly implemented to the doctor's workflow. One of the projects that I was working on, and it's not an AI yet, but it was starting in the roadmap of developing an AI, it was about reducing the DVT post-surgical. We have one of the KPIs in Jowda measuring the post-surgical for 30 days, and we implemented a risk stratification tool in the patient file. Whenever the doctor decides to go to surgery, the risk stratification can be used on the system. They identify the age and other risk factors and so on, and the tool automatically calculating the risk, the percentage of occurrence, and giving the guidelines which specifically needed to be done to the patients. Our plan when we implemented this tool, it was that in the future, the AI will collect the data instead of manual entry by the doctor. It will feature the data from the patient's medical records, and it will automatically calculate the risk and pop up the suggested future preventive management plan to the doctor. So this is one of the Jowda KPIs. So instead of the Jowda KPIs looking, definitely you can use an AI analytical that can sit on your Jowda KPI reports, analyze it for you, and identify the gaps and suggestive corrective action plans. But instead of that, you can go to the root and you prevent the occurrence of the KPI itself. So the doctor wants to shift this patient to a cesarean section, and it's the criteria by the Jowda KPIs for a cesarean section is not applicable to these patients. So the AI can stop the doctor from committing this mistake. So instead of analyzing the mistakes at a later stage, which is an AI also can support, but in spite of that, you are proactively preventing the doctor from shifting this patient to a cesarean section. So by default, your KPIs will improve. I don't know if we have further questions, further sessions.
I'm Arun
Yes.
Govind. I have a question. How the AI can be useful in value-based care?
Okay. Yeah. Thank you so much. It's a valid question. Actually, the value-based healthcare is one of the favorite things that we have for the AI, because you have standardized guidelines. So let's say very, very simple, you have standardized guidelines for treating UTI. Right? So sometimes doctors will go to an antibiotic that is very expensive, and it's not the first choice of antibiotics according to these guidelines. Okay, so there is a lot of AIs that nowadays is embedded inside the EHR, looking into the diagnosis and the other parameters like the age, the gender, the lab results, the culture, and so on, and collecting these data. And once I put that this patient has a UTI, E. coli UTI, it's automatically calculating all of this and suggesting the management plan for the patient. So instead of, for example, you know that I'm a pediatrician, so the pediatric guidelines for NICE guidelines for UTI, if the patient is below 3 years old, there is guidelines, set of guidelines, and another guidelines if above 3. And below 3, you have two different settings. One is for male and one for females. So, for example, in the male, if they have recurrent UTI at the age less than 3 years, they might have a reflux. They might have a lot of surgical conditions that can be there. And some of the doctors, they miss that. There is a UTI and they start treating the patients instead of ordering a micturating cystourethrogram, for example, which is one of the first things that we have to do it for a male because they might have a valve deformity. So again, the AI can help you. And some of the doctors, they will go for a female under 3 and immediately ask for a DIMSA scan and micturating cystourethrogram, which is very expensive and consuming the insurance and the budget for these patients, which is not required according to the guidelines. So the value-based is that you are taking your guidelines, implementing into the machine that looks into the parameters inside the EHR of the patients and suggesting the most cost-efficient and the most accurate guidelines according to these parameters. So yes, it can help you a lot if you are following the value-based healthcare.
How do we
I hope I
strike
answered
a
you.
balance? How do we strike a balance between the judgment of the doctor versus the judgment of AI-enabled algorithm-based systems when it comes to value-based care, which will have an implication on the reimbursement from insurance, and the management can turn against the doctor because the judgment of the doctor was wrong when it came to the AI in value-based care. So, what is your experience?
So, see, like I said, I'm not a big fan of taking the leadership from the doctors. The doctor is the doctor; he's the one treating the patients because there is no AI on earth is actually touching the patient. But your doctor touches the patient. So there's a lot of things they know that is outside the EHR. The other thing is that what the AI validation is very, very important. So you have to have a doctor's brain sitting with you during the validation, telling you that this decision sounds right or sounds wrong, and you modify the way that the machine. And that's why we said the machine learning is very important in healthcare because it keeps learning according to a human decision. Then we move to when the decision is taken and the pop-up message comes to the doctor. The machine doesn't order anything. The machine suggests a management plan according to a limited data set that is we feed the machine on. But there is other things around it. There is a mother that doesn't want to start an antibiotic now, and she wants to wait. There is a patient that cannot take these medications because they are non-compliant. They cannot take daily. So instead of taking daily glucophage for controlling of their pre-diabetes, for example, I would like to go for Ozempic, for example, that I will take the injection on weekly basis. Okay, so this conversation with the patient between the patient and doctor the machine will not never see it. So what I always suggest is there is a suggestive management plan depending on the limited vision of the AI. It pops up to the doctor, and the doctor either acknowledge and proceed, or acknowledge and edit, or reject. And whenever they acknowledge and edit or reject, they need to tell us why, because we want the machine to learn from their decision, how they thought about it. So there is always a reason of editing or a reason of rejection. So if I select edit, now I'm not going to use a glucophage for the prediabetes, then I have to tell the machine, why did I change the suggested? And the machine will self-learn in the future to tell the doctor, would you like to add Ozempic instead of the glucophage for this patient? And so on. So again, validation, stakeholders engagement, testing and revalidation, continuous monitoring, and give the doctor the final autonomy to decide what's best for their patients.
Thank you, Dr. Dina.
Welcome. Thank you.
Thank
Thank
you
you for
so
the
much
question. It's very nice.
Yeah, Mr. Arun is always asking excellent questions, thought-provoking. We have two more questions. One is from Dr. Malti and second is from Dr. Light. Dr. Malti has asked this question: what is the cost implication for the implementation of AI tool, for example, for stroke in Mediclinic or any other independent module?
I'm not sure if I got the question right.
Dr. Malti,
So the
you
cost.
can unmute yourself if you want to ask this question.
Yeah, thank you very much. And thank you for the wonderful presentation. I always would like to know about cost implications because there are so many of these modules coming in and approaching us for the implementation of some of these modules. Since you talked about Mediclinic and the presence of the stroke tool, maybe there is some idea on what would be the cost implication of the AI tool. Would it vary from, like in this case, you said it is already embedded in the machine and can be used, whereas another module could be an independent module. So any idea, I know it could vary from module to module, but some ballpark figure, because it's coming in a big way and hospitals are repeatedly approached for a number of AI tools. So some idea about it, is that a possibility of giving us some information?
To be honest, because I'm a previous employee in Mediclinic, so I cannot give numbers, but I will tell you how it works. It works by identifying a problem, then looking for a solution, and then you have a return of investment. There is a lot of tools and tables that you can use to build the return of investment. You can look into the turnaround times, saving money. You transfer the turnaround time to $sign. You look into the previous cases where you missed some of the cases, or there is a delayed treatment that happens and that you had to give financial settlements for these patients, and you ask the finance and the legal team to give you some figures about these cases. You can look into the sorry, I think someone
just a second. Yeah, please go ahead.
You can look into the ability to serve more patients if you have the AI in place. So some of the nursing director of nursing I met, that they come with huge staffing numbers. They want to recruit more, and the reality is that they don't need a nurse. They need an automation and a better understanding of how the technology can help them in the documentation. So you can instead of hiring more nurses to babysit your system, you can develop an AI and automation of the system that you don't need a human nurse, which will cost you thousands, and maybe you will never get it. Usually the HR and recruitment team, they never approve this budgeting for new staffing. And in reality, if you look into the details, you will discover that you don't have a shortage, you have a burnout. Instead of shortage, you have nurses and doctors utilized for data entry instead of serving patients. So you recruit more for data entry purposes. Instead of that, build your return of investment that you will save how many doctors. And sometimes the finance will be very helpful. They can give you the value by minute per physician and per minute per nurse, and it help you to, I will save 1,500 minutes from the nurses, and the minute per nurse cost me this amount of time, so I'm saving this. And this help you to build your return of investment. I hope that I answered it correctly.
Dr. Martin.
Thank you.
Great. We can always connect offline and we can discuss this further. Sure. Great. So I think one more question, Dr. Light, you had raised your hand before. Light Kader.
Yes, I had a question. Dr. Dina, thank you for your presentation and sharing your expertise. And Deepinder, thank you for your coordination. Regarding the challenges, one of the challenges that I had in mind, which is regarding the clinical autonomy and the responsibility. Now, like what I'm thinking is humans tend to think less when something else thinks for them. So how can we overcome this challenge, since AI in healthcare is a two-edged sword? So I think that it gives us the benefit of support, but it also has the other edge of the sword, which can lead to clinicians or healthcare workers to depend totally on it. So what are some measures that you know of or you have done before that overcame those challenges? Please.
Okay. Thank you so much, Dr. Light. To be honest, the dependency on the AI is unavoidable. Even sometimes I noticed myself that I know where I'm heading. I know that I'm going to my work, where I'm going every single day, but I'm still using the Google Map. And the reason I'm doing that is that I know exactly the route that I'm going every day, but I cannot predict whether today there is a traffic congestion on this road or not. Well, the Google Map can predict this for me. So being dependent on the AI is something, to be honest, I think it's unavoidable. It always comes to the validation process and making sure that your doctors are aware that the legal liability sits with them. The AI will suggest, will predict, will recommend, will give you multiple options and choices, but again, the choice is yours. If you choose the wrong dose, it's your responsibility. We cannot blame an AI for it, because the AI will suggest for you, you are the decision maker. So again, when someone asks me, where is the medical legal liability sits with? The medical legal liability is not changing, whether it's a human brain or it's an AI. So let me say it differently. If there is a resident working with me, and the resident, I'm telling him to calculate the doses, and we will start this and this antibiotics or anticoagulants for this patient, and he mistakenly calculates the wrong dose, And while I'm validating their orders, I didn't notice it, and I just proceeded with what they suggested. Where is the medical legal liability sits? It sits with the consultant, not the resident. We cannot blame the residents because I'm overseeing them. The same is happening with the AI. So make sure that whenever you recruit an AI or an automation solution, you make it clear to the clinical leadership that the medical legal liability, like ever, it will continue being with the doctor and the nurses and the clinicians. I think like this is one of the methods I use it to give them the sense of the responsibility and to reduce their dependency and the AI on the AI. You are in the driver's seat and we are not replacing you. We're just adding a navigator or a co-pilot next to you. That's all.
And I think you already answered one more question by Mr. Mohammed Haris. He had a question that how can AI be used to support and not replace healthcare professionals?
I'm always telling the healthcare professionals that the AI will never replace you, but physicians and the clinicians and healthcare workers using AI will replace you. So if you are not up to speed, you are not updating yourself, you are not engaging with the new AI era, you don't need an AI to replace you. Your own colleagues who knows how to use a robot. So the surgeon who uses a robotic technology is going to replace a doctor who is refusing and always not using a laparoscope and depending on open surgeries. They will replace each other. You don't need an AI to replace them. This is the reality nowadays.
I think that's a very important thing what you just mentioned. It's updating with the technology, and I think all of us should definitely have to learn how to definitely use the AI to help us and our organization definitely. Dr. Dian, last question we'll take as of now. Dr. Jenny John, you have a question, please go ahead.
Thanks,
My
Deepinder.
dearest
Thanks very
friend.
I just wanted to say it's always a pleasure to hear you, especially a physician who talks so passionately about AI and clinical decision making tools. I think, Dr. Dina, I think one of the things that we need to really address is either most of the full-fledged hospitals are already onto electronic health record or are in the process of transformation or transforming into the EHR. But I think what's really lacking at this point of time is an internal governance. As much as we talk about, we need the regulators to put in guidelines. We want them to approve the vendors, the suppliers, but having an internal governance within your health system, where what is the role of the clinician? I did notice you said that we need to involve the stakeholders from the beginning, from the time of inception of an EHR to advancing it and to adding interoperability, etc., etc. But I think what a lot of times healthcare facilities fail to do is get the leadership commitment in. Where do you think, how do you think, where is the solution to that? It's not, I know it's always ROI. You did mention that, you need to convert those numbers to a return on investment. Whatever you put in, how did it benefit the organization? But I think then we need to approach it from quality, from clinical informatics perspective, to get these people or the leadership team to get a buy-in from them. Because the doctors are already onboarded. They used to be the challenge at one point of time, not anymore.
I totally agree with you, Dr. Jenny, the internal governance, and that's why I was so enthusiastic to attend this meeting, because when we talk about governance, you are the champions. So yes, you're right. And it's never too late. Even if you have your EHR implemented 5 years, 10 years back, it doesn't matter. You can always step in to improve the process. What I noticed is that there is a technology, let's say a stakeholder, a clinician, a nurse, a director, a medical director, and so on. They identify a problem and they directly go to the technology people saying, you know what, I want an automation of these machines. Yep, sure. Just make the case, business plan, blah, 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 and then plug in. And when I'm sitting on the final stages, I always ask, where is the quality? Patient portal, for example. The patient portal, we look to it as a purely technology platform. But if you look clinically to it, the patient portal is an automated release of medical information. So now every single one, they have in their medical records a policy of releasing medical information. And when we have the portal, where is the implementation of this policy? It has to be implemented.
Right.
Whatever not released on the medical record side, it cannot be released on the. So if I'm saying that the medical records team, they cannot release, for example, medical reports from a psychology or a psychiatrist doctor directly to the patient. It has to be approved first by the doctor. Let's say that our policy include that, okay? Then when I build the patient portal, I will tell the vendor that any medical report that lies under this category cannot be released. It has to be the process that the request will go to the doctor and the doctor will validate and approve the release before the portal can release it. So such a tiny things that as a technology person, as a developer, as a vendor, they will never look into it if the medical records, if the policy makers, which is a quality department, is not involved in every single solution implementation, then we are in a big mess. And it will be discovered one day. One of these medical reports, for example, will be released mistakenly to the patients, and a regulator will hit us very bad. So thank you for asking this. Internal process and internal governance is a key.
Thank you, Dr. Dina. Wonderful.
Thank you so much,
presentation.
Jenny. It's
Thanks.
always a pleasure to hear your voice.
Likewise.
Thank you, Dr. Jenny, and thank you, everyone. In the interest of time, we will be ending the session now. But all your queries, please put on the chat box. We'll connect and try to answer those queries. And special thanks to Dr. Dina for sharing the real knowledge with us, because knowledge is available in the internet in other ways, but when a real person is talking to us in terms of what that person has done in the industry, how the contribution has been, and what are the challenges, so it becomes very imperative for all of us to gain that kind of knowledge. So thank you, Dr. Dina. Really appreciated your time
Thank
and
you so
efforts.
much.
And thank you, everyone, for joining in. We'll be looking forward everyone to join in the next series, which is going to be continuing for this year. Thank you, everyone.
Thank you so much. Thank you. I appreciate it. Thank you.